Okay, welcome back from the coffee break. I trust you're still alert and excited about the rest of this afternoon's program. So the next talk is virtual. And there's a slight change in the program, so we will start by the second talk on this afternoon's agenda, and that is Dr. Jonas Reis from the University Clinic of Munich, who will be speaking about using metabolic perfusion markers in gliomas. And please go ahead, Dr. Reis.
Yeah, thank you for the introduction and also for the invitation. Although I would like to be with you, all of you in Paris. Nevertheless, I'm happy to talk about metabolic perfusion phenotyping and glioblastoma, and specifically about how these signals may lead us towards clinical relevant imaging biomarkers. The main theme throughout the talk is that metabolic perfusion is not yet a clinically qualified biomarker or group of biomarkers, but it is increasingly becoming a credible platform for biomarker development. I will structure the talk around three simple questions. First, why is the peritumoral brain zone our target? Second, what do metabolic perfusion phenotypes tell us about tumor biology? And third, what is still missing before these signals become clinically relevant imaging biomarkers? Let's begin with the peritumoral brain zone. Just a quick overview. The reason we focus on the peritumoral brain zone is that that is the biologically relevant space beyond contrast enhancement, or the contrast-enhancing tumor core. And this compartment is the non-contrast enhancing tumor-brain interface. And importantly, it's not just edema. As illustrated here on the left side, it is a heterogeneous microenvironment that may contain infiltrating tumor cells, reactive changes, altered vasculature, and immune activity and extracellular matrix remodeling. Clinically, this matters because glioblastoma recurrence is still predominantly local, usually near the original lesion or the resection margin. So if we want imaging biomarkers that go beyond simply describing the enhancing core, the peritumoral brain zone is, for me, a very plausible place to look. And I think this statement down here is summarizing the importance of the peritumoral brain zone quite well. It is where tumor biology, host response, and future recurrence intersect. When I say clinically relevant imaging biomarker, I mean something quite specific, and I will demonstrate it on this practical roadmap with only some key points shown for clarity. First, we have to define the intended use: diagnostic, prognostic, predictive. Second, we have to show analytical validity. For example, the signal has to be robust across scanners and sites. Third, we have to prove biological validity. The imaging phenotype has to relate to a meaningful tumor biology. Fourth, we have to achieve clinical qualification. The biomarker has to predict relevant clinical endpoints, of course. And finally, there has to be utility. Clinically relevant imaging biomarkers should change decisions and be scalable in practice. I would say that our current work in Munich is rather at the beginning and sits mainly between analytical robustness and early biological relevance. And that's also the level of claim I want to make today, not more. That is or was the kind of case that first made us think that model-based metabolic perfusion imaging might be showing us something clinically meaningful. This patient with glioblastoma was imaged at follow-up after radiotherapy, I think 12 months. And on the T2 and T1 post-contrast, we see a new lesion that is hard to differentiate between pseudo and true progression. Here we see the matching vendor-derived RCBV and CMN-derived RCBV maps. And the vendor map is not very convincing, but the model-based map shows a clear perfusion hotspot in the suspicious region. Accordingly, our verdict or our diagnosis was suspected tumor recurrence or progressive disease. But the initial pathology report described only reactive CNS tissue or changes, which of course made us think about our diagnosis and also about the perfusion signal. But the molecular pathology diagnosed a new glioblastoma manifestation alongside reactive changes, and that was also supported by marked progression in the short interval follow-up with predominantly contrast-enhancing tissue beginning necrosis and also like swelling, but the clinical cause did not match, and of course the pathology pseudoprogression. Of course, this is just one case. It does not validate anything, and especially not a biomarker, but it gave us a first sense of clinical plausibility. Perhaps there is a biologically relevant perfusion signal that becomes more visible with this processing approach, and that was just CBV. The obvious question after a case like that is whether this is only a visual impression. So we looked at this more systematically and compared CMN versus vendor post-processing for untreated glioblastoma. And we focused on perfusion hotspots in cerebral blood flow, volume, and mean transit time to be comparable. The quantitative results from the study are quite straightforward. CMN yields higher normalized metrics of perfusion hotspots in untreated glioblastoma over all three metrics. And as you comprehend from the three plots, the level of significance was also quite high. And importantly, this was observed across heterogeneous field strength and different scanners. We interpreted that as a support for analytical robustness, or we could say assay sensitivity in real-world MRI, but definitely we cannot interpret it as final technical validity. For that, we would still need stricter repeatability, reproducibility, and probably external standardization. But for us, as a step on the proposed roadmap, it was encouraging. Against that background, we then performed two studies that are the core of this talk. Both are retrospective single-center studies in adults with untreated glioblastoma as a baseline. The first study is contrast-enhancing versus non-contrast-enhancing phenotype study with 72 patients and 66 paired cases. The second study investigated the association of peritumoral brain zone perfusion with proliferation with 80 patients. For both studies, imaging consisted of routine clinical GRE DSC perfusion, diffusion imaging, T2 flare, and post-contrast T1, all acquired on multi-vendor 1.5 and 3 Tesla systems using a standardized gadobutrol preloaded bolus. And we used region of interest sampling in the solid enhancing core, the adjacent non-enhancing T2 flare abnormality, or PBZ, and in the contralateral normal appearing white matter. Post-processing was performed with CMN, and we analyzed CBV, CTH, OEF, CMRO₂, and ADC after combat harmonization and normal appearing white matter normalization. And for us, this is a pragmatic region of interest-based starting point, mainly because our historical routine data set is too heterogeneous and not just always, it's not ideal for automated segmentation. The first study started from a very simple observation in a typical untreated glioblastoma. The large contrast-enhancing core clearly showed matching high CBV and high CMRO₂ signals, but oxygen extraction fraction and capillary transit time, capillary transit heterogeneity did not just mirror the enhancement in an obvious way like the other two. So that already just suggested that perfusion capacity and also so-called capillary function may behave differently across these tumor compartments. So the next step was to test this systematically. And in this paired analysis, the message, I think, is quite clear. CMRO₂ is higher in contrast enhancing than in non-contrast enhancing tissue, with the median ratio of 5.31 versus 1.64, and also a highly significant effect. And CBV is also clearly higher in CE, again, highly significant, and ADC is lower in CE contrast-enhancing tissue, which is compatible with denser tumor compartment. And these two, I think, are kind of a positive control and nothing new. By contrast, oxygen extraction fraction and capillary transit heterogeneity were not significantly different between contrast-enhancing and non-contrast enhancing tissue in this region of interest analysis. But the results are also illustrated here in these four plots with the unidirectional intrapatient, or mostly unidirectional intrapatient relationships for CMRO₂ and RCBV, and the crisscrossing intrapatient relationships for OEF and CTH. So my interpretation of the first study is that the contrast-enhancing compartment is the obvious macroscopic high-throughput vascular metabolic compartment. But the more interesting point is that the capillary function indices were not consistently compartment restricted. Or we could say biologically meaningful perfusion information may extend beyond contrast enhancement. And the limitations are important, and I want to state them explicitly. It is a region of interest-based sampling without spatially co-registered histology or PET, and also without clinical endpoint validation. So this is definitely not a biomarker claim, but is a physiologic phenotype, and it pointed us directly toward the peritumoral brain zone. Accordingly, the second study then asked whether the peritumoral brain zone contains a biologically meaningful signal, and this is a first example, again a textbook glioblastoma with a large necrotic core and enhancing rim and peritumoral brain zone here on T2, and also with a high Ki67 proliferation index of around 20%. And the main point is not that the enhancing core itself or the enhancing rim, but the non-enhancing peritumoral brain zone. On the oxygen extraction map, it appears visibly more prominent, and for us it suggests increased oxygen extraction beyond the enhancing rim, the enhancing high CBV rim. This is a contrasting case with, of course, a less prominent tumor in morphologic or structural MRI, but also with a low Ki67 of around 5%. And again, these images are illustrative only, but here the peritumoral brain zone OEF signal is much less striking or not apparent, especially if you note the clear CBV hotspot. So the visual impression from these two examples was that the relevant difference may sit outside enhancement, and it may sit in the peritumoral brain zone. That motivated the formal correlation analysis I'm going to show. This is the key result of the second study, peritumoral brain zone oxygen extraction fraction showed a modest patient-level association with Ki67. In 80 patients, the Spearman rho was 0.27 with a nominal p-value of 0.014 and Beniamini-Hochberg false discovery rate adjusted Q-value of 0.06. By contrast, the available CE subset of 69 patients, CE OAF, did not show an association with Ki67. And also the other CE metrics did not remain significant after false discovery rate correction for PBZ as well as for CE, shown here. But importantly, the signal was directionally stable in the age and sex-adjusted sensitivity analysis, where the partial rho was 0.28 with a permutation p-value of 0.008. Then we asked whether the peritumoral brain zone signal is simply a spillover from the enhancing core. And in a linear regression model that included contrast-enhancing OAF, the peritumoral brain zone OAF remained independently associated and also improved the model fit. So in other words, the peritumoral brain zone signal seems to add something beyond contrast enhancing. And at the same time, I would still be very careful about how far we can interpret this. It's still a region of interest-based sampling. It's a patient-level association and not a spatially co-registered comparison between PBZ, perfusion, and histology, and still no clinical endpoint validation. So I would describe this as early biological relevance and definitely not biological validation. But I think this conclusion here is justified. The peritumoral brain zone oxygen extraction fraction phenotype provides us with a non-enhancing physiologic signal linked to a patient-level proliferative activity. So what's still missing before we can call metabolic perfusion phenotyping a clinically relevant biomarker? I would summarize this in 3 requirements. First, we need standardization. Additional to the scanner and field strength robustness, the signal must be reproducible across heterogeneous DSC acquisition and processing settings. And second, of course, we need spatial validation. The phenotype must be anchored to spatially matched pathology, or at least PET-informed biology. And third, we still need clinical qualification. The biomarker must improve prediction beyond the standard MRI. Ideally, it should reach ranges of FAT-PET, the ideal. And this is really the central translational message I want to give. A promising physiologic signal becomes a clinically relevant biomarker only when it is reproducible, biologically anchored, and also endpoint linked. And that is also why I would call our early work in Munich an early stage biomarker development path. And it's definitely, hopefully, not our endpoint. And finally, what do our data support today? Data from Munich. I think there are 3 points. Again, first, model-based metabolic perfusion improves usable signal in heterogeneous routine MRI. Second, the capillary function signal is less tightly compartment restricted than perfusion capacity, meaning that biologically meaningful perfusion information extends beyond the contrast enhancement. And third, for us, the peritumoral brain zone, in the peritumoral brain zone, oxygen extraction fraction emerges as a candidate non-enhancing biomarker that carries a distinct signal linked to a patient-level proliferative activity. Accordingly, my conclusion is that metabolic perfusion is emerging as a credible assay platform for clinically relevant glioblastoma biomarkers, and that the peritumoral brain zone may be one of the most promising spatial targets for this development. And that is also why the next validation layers matter so much. We need to understand more precisely what this signal represents in the tissue and whether it predicts where the tumor recurs, and if we can meaningfully differentiate pseudo versus true progression. And that's it for now. Thank you.
Thank you very much for this very sort of comprehensive analysis and excellent talk. Are there questions from the audience? Yes, there's one there.
Hi. Yeah, thank you for a great talk. Full disclosure, can you hear me?
Yeah, I can hear you.
Yeah.
Thanks.
Full disclosure, I work for SoCare. But I was just wondering where you saw the larger CMRO₂ effect in the contrast enhancing versus non-contrast enhancing regions. Did you consider also correcting for other parameters that we already know, like CBV, for example? Because we're always talking about how none of these parameters are really statistically independent of one another, right? Yeah. So if we're really interested in isolating the effect of interest, did you do it?
No, not yet. We're working on it because our next cohort will be or is bigger, and we will do voxel-wise or are doing voxel-wise analysis. But of course, the quite similar visual impression and also the numbers directed us into the comparison of RCBV and CMRO₂, and unfortunately, we did not do CBF analysis, but I think it has to be proven how much additional value the CMRO₂ gives over CBF, or in this case, the proxy of CBV. But it's definitely a point that's still open.
Thank you.
Thank you very much. Other questions? Otherwise, another round of applause for this excellent talk. Thank you so much for being with us.
Thank you. Thank you.